Hello, my name is Brady Blazek, and I'm currently a senior in the Nurse Anesthesia Doctor of Nursing Practice program at the University of Iowa. A little about my background. I received my Bachelor's of Science in Nursing from the University of Iowa in 2006, and after graduation took a job in the surgical ICU at the University of Iowa Hospitals and Clinics, where I worked there as a staff nurse and ECMO specialist for several years. I then graduated from the perfusion technology program at the University of Iowa in 2012 before starting my training in anesthesia. A portion of my DMP program I'm currently completing requires me to conduct a clinical leadership project, and I've chosen to focus my project on alternative airway management strategies for first responders, specifically with a focus on the I-gel supraglottic airway device, which has some distinct advantages over other devices that are currently being used by EMS in Iowa. Before we get started, I would like to disclose that I have no financial stake in Intersurgical Incorporated. They're the makers of the I-gel device. I am not being compensated in any way for providing this training. And I'd just like to let you know that Intersurg Incorporated did provide me with some sample devices for training purposes, free of charge. So by the end of this lecture, I would like everyone to be able to describe correct insertion of the I-gel airway device. I'd like you to be able to describe the various functions of the I-gel. I'd like you to be able to discuss some troubleshooting options and successfully demonstrate correct insertion of the I-gel during a hands-on skill lab. As first responders, what are some of the options available for airway management? Well, there's standard endotracheal intubation, which is great when that's successful. There's also bag valve mask ventilation, which requires both hands and can be somewhat difficult and kind of air prone, especially in the field, particularly if quantitative end-tidal CO2 measurements are unavailable. And it also increases the risk of regurgitation and aspiration due to insufflation of the stomach. Another option are supraglottic airways. I'm sure that most of you are familiar, or at least have some experience with the King LT or the combi tube. Other options include various LMAs or laryngeal mask airways that have inflatable cuffs. And more recently, a device that's come to the market is the I-gel resus device. So I'd just like to talk a little bit about endotracheal intubation because it has been considered the gold standard for airway securement for a long time, mainly because it was the only device available during the early days. But is endotracheal intubation still the standard of care in the pre-hospital setting? I would say in some situations maybe yes, in others maybe no. In reality, providing adequate ventilation, oxygenation, and perfusion is the standard of care and not really by the route by which it occurs. So the American Heart Association now places circulation before airway in their algorithms. So endotracheal intubation is a rather difficult skill that requires a lot of repetition to gain mastery. Research has shown that the average practitioner requires somewhere between 50 and 60 elective intubations under controlled conditions to reach a 90% success rate on the first attempt. So that's in the OR, you've got the head at your chest and nobody's thumping on the chest. It's a still patient, ideal situations. They've been 100% pre-oxygenated. And there is a strong correlation between intubation success rate and accumulated experience. And it's estimated that it takes greater than 100 repetitions before cortical ingranation occurs. And additionally, the American Heart Association recommends that providers have at least 6 to 12 intubations per year to maintain their proficiency. So if you work in a busy metropolitan area, maybe you will be getting enough repetitions to maintain proficient. but maybe you work in rural Iowa, you intubate a couple of times a year, it's unlikely that you're going to be able to meet those recommendations and stay proficient at intubation. So how successful are paramedics at intubation? Well, it turns out that y'all are pretty good, with an overall success rate of 87.1% in the pre-hospital setting, according to one study. But only about 65% of those are successful on the first attempt, and about 30% of those require more than one attempt. And it's a well-known fact that greater than two attempts at intubation increases airway-related complications, such as hypoxemia, regurgitation, aspiration, bradycardia, and cardiac arrest, up to 14-fold. There is now some evidence that's pointing to decreased survival rates for out-of-hospital arrests that are managed with intubation. Currently, there really is no consensus on the best practice, but there will be some evidence coming down the pipe. So I talked a little bit about bag valve mask ventilation, but it can be difficult and air-prone, particularly on patients who are edentulous, have large BMI, maybe suffer from sleep apnea, have facial hair. The I-gel device provides a more secure airway. It improves ventilation, and it also allows for one-handed bagging as opposed to two-handed bagging. It also gives you a better seal and allows for higher peak airway pressures if you need them. And it also protects against gastric insufflation, which further reduces the risk of aspiration. So compared to the King LT, the I-gel is about 30 seconds faster to insert. The two devices have roughly equivocal success rates. Overall, the I-gel has about a 98% success rate. The King LT is about 96%. The I-gel does have a built-in bite block that helps with negative pulmonary aspiration, keeps that patient from biting down on the tube. It also has sort of an elliptical shape to the device itself, which stabilizes it between the patient's incisors or gums. It doesn't allow it to be twisted. And the I-gel can also serve as a conduit for intubation, which I'll discuss a little bit later in my talk. And it doesn't have any moving or inflatable parts or cuffs that could tear. This means you don't have to test the device before you put it in. It decreases the risk of mucosal damage and necrosis, and it may also reduce the risk of carotid artery compression, which theoretically will increase cerebral perfusion during CPR. Now, admittedly, this has only been validated in porcine models, and I'm guessing there weren't a lot of people that were lining up for that study. So what is the I-gel? Well, what it is, it's a second-generation supraglottic airway. It's a single-use device. It's latex-free, and it has the non-inflating cuff that we talked about. It's made out of a gel-like thermoelastomer material. Currently, the EMS version is available in 3 adult sizes. Pediatric sizes are available for anesthesia, but currently they are not available for the EMS, but they may be coming down the pipe in the future. So is the I-gel device a primary airway or a rescue airway? And the answer to that question is it can be used as both. So it can be used as a replacement for bag valve mask ventilation, or as an intermediary prior to intubation to oxygenate the patient. It can also be used as a first line when difficult intubation is anticipated, so rather than attempting intubation, you can place this device. It's also, if intubation is not possible, if the patient position prohibits intubation, or the patient needs an airway prior to being extracted from a vehicle or something like that, the I-gel can be placed in pretty much any position. And it can also be used as a backup for a failed intubation or to facilitate intubation. So what are the benefits of using this device? Well, you may be thinking that, oh, my intubation skills are great. I already like the King LT. I'm happy with it. It works as well for my rescue airway. So just a kind of overview of the primary benefits. The I-gel's fast insert, 5 seconds. It's reliable, a high success rate, 98%, and it's also atraumatic to place. You don't need to interrupt chest compressions. It's a very simple device, no moving parts, and it's stable once you get it in there. It also has the bite block and a gastric channel to reduce the risk of aspiration, which may improve, and the device itself may improve survival rates. The Revive Airway study, it's a pilot study that was conducted over in Great Britain, included 184 patients that were enrolled, and it compared the I-gel to the LMA Supreme to endotracheal intubation for airway management and out-of-hospital arrests. And they actually terminated the LMA Supreme arm early due to poor outcomes, and so they finished off the study comparing the I-gel to endotracheal intubation, and they compared survival rates to discharge from the hospital and at 90 days. And as you can see, the I-gel was a little bit better than intubation and quite a bit better than the LMA Supreme. The Revive Airway 2 study, which is the follow-up to that initial pilot study, is currently underway with data is to be expected in 2018. This study looks to enroll about 9,000 patients, and it's going to be comparing the I-gel to intubation. And they're not only going to collect survival data, but also quality of life data, cognitive function, time to ROSC, or return of spontaneous circulation. They're going to compare ventilation success rates, regurgitation aspiration rates, as well as the overall cost. And then with that study, they're also going to look at the preferences of paramedics to see what they prefer. So this is just an overview of the I-gel device itself. Starting on the left on the top, that's the hook ring where the mask straps connect to. Points out the gastric channel where you can pass a gastric tube. It's the non-inflating cuff. That's kind of where the contact takes place between the device and the laryngeal framework. I've got a supplementary oxygen port, which I'll talk about. There's the rigid bite block that's integrated into the device. And then they call it buccal cavity stabilizer, which basically just keeps the device from twisting and turning in the mouth. And then the epiglottic rest it's basically the little aperture that holds the epiglottis up and out of the way of the glottic opening. So the I-gel is being marketed in the US to EMS services in 3 sizes. It comes as a pack that includes the device, a strap, and a little packet of lubricant. The packet outside of the US contains a gastric suction tube because some EMS guidelines in the US prevent gastric tube placement. The tube's just been admitted from the US market. So the device itself has 2 hook rings shown here in red that allow for easy attachment of the device strap. This is particularly advantageous for trauma patients that maybe have a bloody airway or bloody face, or situations where tape is going to be ineffective. So the included lubricant packet is nice because you don't have to worry about having lubricant. It's just right there for you to use. Helps to facilitate insertion and also the gastric tube placement. So here's just a highlight of the gastric channel. The tip of the device sits in the distal esophagus and allows for the tube to be placed pretty easily. Just sort of guides it right down the esophagus. And then if you're not allowed to place a tube or you don't have a tube available, that gastric channel actually allows for an early warning of aspiration, as you'd be able to visualize gastric fluid coming up that channel, which would allow you to take some action. So the size 3 and 4 devices will accept up to a 12 French gastric tube, and the size 5 will accept up to a 14 French. So to use the gastric port with the gastric tube, you just apply a little bit of lubricant to the gastric port opening, and you kind of prime that port by moving the tube in and out a few times, and after that the tube should pass easily. And after the tube's been placed, you can apply suction at an appropriate level. So I'm going to touch just briefly about passive oxygenation because it is an option on the I-gel device. The port allows for the delivery of oxygen without assisting ventilation, which can be administered with either oxygen tubing by connecting it directly to that channel or using an O2 mask. There are some literature that supports the use of passive oxygenation during a witnessed arrest. I'm not going to go into detail with that, but the port can also be utilized if the patient is spontaneously breathing. You can just apply some oxygen there and let him breathe passively. So here's just a close-up of the passive oxygenation port. When using the device to administer positive pressure ventilation, however, that port does have to have a cap on it. Otherwise, you're not going to be able to achieve any positive pressure. And this slide's just showing how passive oxygenation would be utilized in the field. Somebody else is doing compressions, and you're just hooking up that oxygen to the port, or perhaps the patient's breathing spontaneously. And this slide just demonstrates how the I-gel is used conventionally with a normal positive pressure bag. And I just want you to notice that passive oxygenation port is capped off. So selecting the correct size is a really important step for the device to function properly. The sizing is color-coded, and it is also done according to ideal body weight, not actual body weight. So that's kind of an important distinguishing factor here. I kind of wish they'd size these devices according to height rather than weight. But just know that the size 4 will work for about 85 to 90% of the population. So it's probably your go-to size. The size 3 is for smaller adults, and the size 5 is for larger adults greater than 90 kilos. So after you've picked the correct size, you just open up the pack, and there's a little tray in there that has the mask strap and lubricant, and you just want to set that to the side. You want to open up the lubricant packet and squeeze some of it into the packaging. You then want to lubricate the back, sides, and front of the device with a thin layer of lubricant. You want to try and avoid getting globs on the front of the device, which may cause some airway irritability or even laryngospasm. So when you're getting ready to place the device, you want to grab it in one hand where the bite block is in the device. Use a head tilt and a chin lift when it's not contraindicated, similar to placing the patient in position for intubation. You want to hold the device so the cuff is facing forward towards the patient's chin, and introduce the soft cuff portion of the device into the patient's mouth, gliding along the hard palate. You want to keep advancing the device downward and backward along the hard palate with continuous but gentle pressure until you meet a definitive resistance. If early resistance is encountered, you can perform a jaw thrust and attempt to advance the device again. If you have a partner with you, have them do a jaw thrust while you attempt to advance the device. And if resistance is still encountered, attempt what's called a deep rotation. So you're basically just twisting the device and you're trying to get that bowl to slide through the fossil pillars. If resistance is still met even after attempting a jaw thrust and a deep rotation, go ahead and remove the device and select a device that is one size smaller. So when the device is placed appropriately, the tip of the airway should be in the esophagus. The gel cuff should be against the laryngeal framework, and the patient's incisors or gums should be resting on the bite block and very close to a black line that's on the device. That kind of is a good indicator of how deep you should be. After the device is in place, secure it using a mask strap. You don't want it to be too tight nor too loose. Alternatively, you can secure the device with tape, similar to how you would secure an endotracheal tube. After the device has been successfully placed, you can begin positive pressure ventilation. If a leak is present, it may get better as the device warms up and conforms to the patient's anatomy. But if the leak is really large and does not resolve, you can attempt a device that is one size larger or one size smaller to see if you can get a better seal. So just to recap, the I-gel can be placed in about 5 seconds. Sometimes a feeling of give way is felt before the endpoint resistance is met, and that's due to the passage of the I-gel bowl through the fossil pillars. It's important to continue to insert the device until definitive resistance is felt. Once correct insertion is achieved and the teeth are located on the bite block, do not repeatedly push down or apply excessive force to the device. And manufacturer recommends that no more than 3 attempts on one patient should be attempted. Also, it is not necessary to put your fingers or thumb into the patient's mouth, but sometimes if the patient has a large tongue or you're by yourself, it may help to sort of depress the tongue with your thumb while you're pulling up on the jaw while you place the device. I've noticed that just with my own experience, that can sometimes facilitate insertion. After the device is in, you want to confirm placement as you would with an endotracheal tube. Check breath sounds, look for chest rise, check for end-tidal CO2 if you've got that available. Listen to the stomach. I-gel has about a 95% first attempt success rate and close to 98% overall. Now, I mentioned earlier that the I-gel can serve as a conduit for intubation. The I-gel will accept an endotracheal tube that is 3 sizes larger than the device being used. So a size 3 will take a size 6, a size 4, a size 7, a size 5, a size 8. So fiber optic intubation is recommended by the manufacturer, and it has about a 98% success rate. I'm guessing most of your ambulance rigs are not equipped with fiber optic intubation. So if you're in the field and you do need to intubate, you can either place a tube blindly or pass it over a bougie. Now, it's got a much lower success rate than fiber optic intubation, but much better than nothing. So in a mannequin study, it had about a 63% success with a bougie and about a 50% when it was passed blindly. And this slide is just a link to a video from the manufacturer. Just serves as a really good reference. They do a nice job of talking through placement and how to use the device. And I'll allow you to watch that on your own.
Problem solving. I-gel is easier to use than many other supraglottic airways, so problems should rarely be experienced, providing the user has read both the instructions for use and the I-gel user guide. Good airway management practice should always be followed. However, it is prudent to consider the most appropriate action to take in the unlikely event that the device is not performing as expected. Most problems can be avoided by ensuring a few basic principles are always adhered to. Ensure the correct size of I-gel is used according to the patient's weight. A good patient position is adopted prior to insertion. The device is adequately lubricated on both the front and back as well as the sides. The lubrication to the sides and front of the device cuff is particularly important and should always be adopted. These simple actions will help to significantly reduce the possibility of problems occurring. Incorrect position. A horizontal line at the middle of the integral bite block represents the correct position of the teeth. If the teeth are located lower than the distal tip of the bite block, then it is likely the device has been incompletely inserted. In this instance, remove the I-gel and reinsert with a gentle jaw thrust applied by an assistant, or a triple maneuver with mouth opening, head extension and jaw thrust, or a deep rotation, in which the I-gel is rotated slightly to aid its passage through the facial pillars before being restored to a normal orientation for completion of insertion. If that does not resolve the problem, use an I-gel that is one size smaller. Coughing and breath holding. Prior to the insertion of I-gel, the following indicators should be used to confirm an optimum level of anesthesia has been obtained: loss of eyelash reflex, loss of response to jaw thrust, loosening up of the jaw, for example, being able to move the chin up and down easily without resistance. Using these simple checks should help to reduce the possibility of the patient coughing or breath holding during insertion. However, if the patient does start coughing or breath holding, then anesthesia must be deepened by an intravenous injection of an agent like propofol or with an inhalational anesthetic agent such as sevoflurane. If the patient is being paralyzed and ventilated, then the adequacy of the muscle relaxation must also be checked with a nerve stimulator. Should a patient show signs of gagging or coughing during the recovery phase, remove the I-gel and adequately suction the pharynx. Air leakage through the gastric channel. A small air leak, air venting, through the gastric channel may be a useful mechanism to protect against gastric insufflation. But an excessive leak means the device is probably not seated properly, and that the airway and gastric channels are not isolated from each other. In such instances, remove the device and reinsert with a gentle jaw thrust applied by an assistant, a triple maneuver, or a deep rotation. Inadequate seal pressure. Seal pressures with I-gel are generally excellent and should be more than enough for both spontaneous and mechanical ventilation. In the unlikely event that seal pressure is inadequate, it is advised to use a larger size than is recommended on a weight basis. However, even if the seal pressure in a given patient would allow it, peak airway pressure of ventilation must not exceed 40 centimeters of water in order to prevent barotrauma. Excessive air leak. If an excessive air leak during IPPV is noticed, use one or all of the following. Hand ventilate the patient with gentle and slow squeezing of the reservoir bag. Limit tidal volume to no more than 5 milliliters per kilogram. Limit the peak airway pressure to 15 to 20 centimeters of water. Assess the depth of anesthesia and muscle relaxation. If all of these fail, then change to an I-gel that is one size larger.
All right, and if you have any questions, please feel free to direct those to my email address down there at the bottom of the screen, brady-blazek@uiowa.edu. I'd be happy to answer any questions that you have. And following several slides are just the references I use to compose my PowerPoint presentation.